طبعا most of the time the death happen from the small non-suspected causes of the shock. So يكون الدكتور عارف انه هذا مثلا يسبب شوك بس ما جاء على باله وتاخر مريض للاسف. Treatment is easy peasy also, so you need to know the trick, the causes of the shock, and they treat it later. شبيبة أنا الصوت من عندي كويس ما في مشكلة. If you look at the definition of the shock from different resources, هاي different، شوف الأحمر هاي different resources اللي جايبين منها definition of the shock. So most of the definition, all the definition, they say something about poor tissue perfusion, which means there's poor blood supplies going to the cells levels. So ما في دم واصل للمنطقة. If you look to the next slide, is talking about the same thing. طيب شبيه كيف الصوت؟ قربي النت. ابراج كامله. طيب ثواني خلينا نشوف فين نسجلها. محمد ودعاني هذا يقول فيرست انا بشوك. ها شبيبه تسمعوا الان؟ طيب والله انا ما ادري مين صاحب الاقتراح هذا اللي حطها بلاك بورد. ملف برجعه الان. انتوا طالبين بلاك بورد المحاضره. طيب so we stop at this slide number 5. What we say about slide number 5, so all the definition is going to talk about the same thing. So same definition of shock. So how can we classify the shock? What mean by classification? احلام. الظاهر انا ما حددت موضوع التسجيل، فكل ما ضغطت على موضوع التسجيل يطلع لي من الصفحه. بس ما حددته قبل ما اسوي سيف، عني شفته لكن والله ما حددته لغيته. طيب classification. So we have a primary, secondary. So this is the most common two classification. So anaphylactic shock is one kind of the shock, but it's not under this classification. So what is the primary shock? What is the difference between secondary shock compared to the primary? So the initial shock, when the shock start, we call it primary, which means it's still in a reversible status. So you can reverse it, you can treat the patient on the bed. So if it became secondary true shock, that means patient need aggressive treatment, is irreversible shock. This is the difference between the two classification. So according to the etiology, to the cause of the shock, this is the most important subtype of the shock. So hypovolumic shock, from the name, hypovolumic mean hypovolume. So that means the patient lost some source of the blood or fluid from the body. So cardiogenic is something related to the heart. So the shock caused by the heart. So heart is not pumping, there's something blockage the heart, or the muscle itself is weak, or something blockage from around the heart, around the sac of the pericardium. Septic shock, so originated from endotoxin of the bacteria. So other type of the shock, we have so many types. So traumatic shock due to trauma, either penetrating or blunt trauma to the body. Neurogenic, usually due to spinal cord injury. And hypoadrenal shock. So it's very rare situation. So you need to know about what kind of diseases. You need to be careful to avoid hypoadrenal shock, which is hormonal shock. So hypovolemic shock, the most common, we see it in trauma departments due to accident or due to any cause of trauma. So cardiogenic is due to in old age or trauma patient also we saw it. So septic shock. So which one of those shock is very important to you as a dentist? Which one you need to know about it? So anyone have any answer? So Ibrahim Khawaji said trauma, yes. We saw a lot of cases of trauma. They came in shock. It's related to the dentist. Like what? So we have community assault patient, واحد مضروب برا ومطقوق يجيك multiple jaw fracture, teeth fractures with trauma, with bleeding for somewhere else. So usually this kind of patients, they need to be treated by trauma team. So we call the dentist in the ER, in the OR, to fix the fractured jaws as a maxillofacial surgeon, or to debride the mouth from the broken teeth while during the intubation. But generally, so we need multiple team, multidisciplinary team to treat the patient. So if you ask me this question, so all the trauma, all the shock is related to dentists, because hypovolemia. So you can get the patient in the clinic with hypovolemia. So patient with a blood disorder or patient on blood thinner, you do operation, simple operation like tooth extraction, and then by the end of after 2-3 hours, patient came back with hypovolemic shock due to continuous bleeding, and the bleeding never stopped. So very small simple operations, and patient came with bleeding to die. So is related to your work. Cardiogenic, yes, it can get old patient with cardiac issue while he's on the table, he got cardiogenic shock. So septic is very important in the dentist procedure. Sepsis, periodontal abscess, or any abscess in the mouth and the floor of the mouth. The patient can present with a septic shock. So it's related to your work. And trauma, as Ibrahim said, neurogenic is rarely we see it, but also in trauma patient, because most of the time we have patient. So I saw two patients while I'm doing my program outside the country. So I got patient with multiple gunshot. She had gunshot in the face, in the jaw, with the multiple fractured jaw and tooth, and neck gunshot. So this patient had facial injury plus spinal cord injury. So patient presented to a neurogenic shock. So unfortunately, those kind of patients, when you intubate them, when you do with them just only palliative treat them, they will die by a matter of time due to massive aggressive injuries. So we classify the shock also due to low blood flow. So this is what you need to know. Do you have any question, guys, in the exam? So how can you differentiate between the shock? So you got a scenario about the patient in shock, and then you got question ask you about what kind of the shock this patient had. So you need to know the pathophysiology. So we have shock due to low blood flow. So low blood flow, which means reduce the stroke volume, reduce the blood inside the blood vessels, like hypovolemic shock due to bleeding, due to trauma, whatever. So cardiogenic decrease initially because the cardiac is unable, the heart is not able to pump, is too much blood through the blood vessels, and obstructive also due to compromise the chamber of the heart from around the pericardium. So due to low of the peripheral arterial resistance, so the arterial resistance became more wide. So مثل لما تكون عندك انبوب بلاستيك وترخيه تماما، يقل الضغط داخله فيتوزع كل الدم داخل البلاد vessels. So there is no way for the blood loss outside the body, but the blood is redundant inside the blood vessels. So those example like septic shock due to the toxin, endotoxin or exotoxin of the bacteria make vasodilatation. Anaphylactic shock give you vasodilatation also, and neurogenic shock due to loss of sympathetic and parasympathetic tone of the nervous system. So patient became relaxed with hypovasodilatation also. So there is abnormality inside the body of the blood vessels lead to distributive shock, which means distribute all the blood inside the blood vessels without any loss of the blood outside the body. So the other kind of shock we have vasovagal shock, which is one of the subtype of the neurogenic shock due to vasovagal activation. So you must know the trigger zone of vasovagal. So two of them in the head while you are working, guys. So eyes, she is one of the point of the trigger zone for vasovagal attack. If you hit someone in his eye, he's going to lose conscious. And the angle of mandible, the second area also. So third area is the neck. That means so most of the fight and taekwondo and the other sport, fighting sport, so they try to trigger this trigger zone by knocking out the fighter. So you need to activate the baroreceptor around the facial area. So in the around the angle of the mandible, eye, and neck. So psychogenic. Anyone have example for psychogenic shock? When can we saw the psychogenic shock؟ بالضبط عبد الاله الفيجاس نيرف. So فازوفيجال due to vagus nerve. هذا حتى في يا سلام محمد الودعاني. Yeah. So bad news most of the time drive the psychogenic shock. So somebody came with the bad news, you told him about something bad, and then he collapsed. الفجعة. So he collapsed. A psychogenic shock. A psychogenic shock also, if you look to it itself from inside, is part of vasovagal attack, is under neurogenic at a neurogenic shock. So neurogenic shock, hypovolemic shock, we mentioned it, traumatic shock, burn. How can we get shock from burn, guys? How can burns give you shock? Is hypovolemic shock or normal volemic shock? Burn, yes, by initiating the burn sometimes, but most of the time, wide surface area burn lead to what? Loss of the body fluid, the plasma. So hypovolemic shock. So burn plus fluid loss. So cardiogenic, we'll talk about it. Septic shock. So all of them drive to decrease the oxygen delivered to the cells of the body. So this is the same slide, other classification for the shock and sub classification for the other. So the most important in this slide, number 4. So number 1, 2, 3 is the same thing. So number 4, he told you about distributive shock. What do we mean by distributive shock? We said, so distribute the blood and body fluid inside the blood vessels. There's no loss outside. So like in septic shock, anaphylactic shock, and neurogenic shock. So this is the other kind of shock due to the blood loss. We mentioned it. So what is the pathophysiology of shock? What's happened due to shock? So if you have hypovolemia due to hemorrhage, trauma, surgery, stab, gunshot, whatever, dehydration due to burns. So what's happened to the body? To decrease the effective of the circulating blood volumes decrease. So what's happening if you lost the blood? So there is no more blood is going back to the heart. So heart cardiac output is decreased, decrease the blood flow inside the arterial system, decrease the delivery of oxygen to the cells, need to lead to anoxia, which means decrease the oxygen in the cells level. What's happened to the cells if you have anoxia? So what kind of metabolism usually cells use? So cells use aerobic, lead to ischemia. Yes, before ischemia. So cells use aerobic system, huh? ATP. use the energy, blood sugar as an energy, release ATPs as a power source for the cells. So if the cells don't have oxygen, so the mitochondria inside the cells itself, so turn over to anaerobic metabolism. So anaerobic metabolism, so that means the cells they have some source of energy to survive for a while, but not for a long time. And same time, cells produces very bad toxin, lactic acids and carbon dioxide more. So we told you about that. So at the initial time, this is the time that you need to interfere and stop the progressive irreversible shock. So what is the stages of the shock? So stages of the shock, we have three stages for the shock. So non-progressive. So the initial one we talk about is at the beginning of the shock. Usually the body is able to compensate and hold the physiology of the body. So number two, if you don't treat it, the consequence continue. So it became progressive decompensated. So the body try to decompensate and cover, and the cells try to turn over to anaerobic metabolism. But unfortunately, you don't treat, you don't support the patient, and then become decompensated. And decompensated is the last stage of the shock. So is it's irreversible. So most of the patient, if they reach number three, decompensated, so mostly the mortality rate is very high, is up to 80 to 90%. So من كل 10 8 ل 9 بيموتوا ما راح تلحق عليهم. إذا كان at the beginning is 20%, so by the end is very highly mortality rate. So this diagram, just read about it. So non-progressive, initially how the bodies react to control the. I'll send you all these slides to the leaders now once we finish. Um, so this is how the body react once he feel the shock from inside. So what there is stimulation for a lot of system, the cardiac system, hormonal system, adrenal system. So on the cardiac system, by sympathetic system, increase the cardiac output, increase the heart rate, increase the contractility, and then the vessels, blood vessels, increase the vasoconstriction to increase the blood pressure inside the blood vessel in case to increase the blood supply to the terminal cell by the end of the body. So hormonal system by pituitary and adrenal gland by the secretion, the antidiuretic hormone and aldosterone, increasing the kidney to reabsorb more of the body fluid and decrease the urine output. That's why most of the patients stroke they have decreased urine output, because the body try to get the benefit from each drop of water inside of the body to get reabsorbed by the kidney to inside the bloodstreams. And the adrenal system they have same thing through angiotensin system and release the epinephrine from the supraadrenal gland. So this is the normal physiology guy of the shock, how the body is acting once he feels there is a shock, there is decreased the oxygen to the cells. So if the shock is progress and became decompensated, that means the body can't tolerate more. So the heart can't push more of the blood, the blood vessel can't squeeze, and the kidney cannot absorb more of the body fluid back. So what's happened? So the PO2, the oxygen decrease, cerebral blood flows decrease. It's very important point about the cerebral blood flow. So the brain is the only organ have its own control for the blood vessels. Let's say, so the brain, the first organ feel the shock and feel the decreased oxygen to the brain tissue. What's happened to the blood vessels? So make vasodilatation to increase the blood supply to the brain tissue. So the only organ in the body have auto-regulation for its blood supply. Is very important point. You can get it as a questions guide, this one. So second thing, cellular hypoxia. So as we said, cellular hypoxia turn the cells mechanism to anaerobic mechanism. So increase the BCO2, the carbon dioxide. So if you have increased the BCO2, what's happening? You got metabolic acidosis by increase a body going to react by increase the carbon dioxide wash out from the body by extra respiration. So on the tissue, decrease the cardiac and cerebral perfusion by the time, and anaerobic metabolism, you got lactic acidosis. So at this point, so you need to know what is the most important marker you need to follow up and see if your patient will respond to treatment or no. So what is the most important point, guys, from this diagram? So let's say you have a patient have shock and you have all this diagram in front of you. What is the most important thing you are going to follow and notice on this patient to make sure his response to your treatment while he's shocking? Is it the oxygen? Is it carbon dioxide? It's not called 20. Is it the lactic acid or urine output? Ahlam, good job, Ahlam. So lactic acid is the most important marker for in the shock patient. So if you have any shock patient on the table on the ER, so the first thing we do during assessing the patient for shock, we do the glaucoma score. We assess the patient according to ATLS, ABCD, and then we take sample of the blood, arterial blood sample. So arterial blood sample, we do the blood gas number one. In the blood gas, we are looking for number one, the first things. So lactic acid, how's the lactic, is the patient acidotic or not acidotic? If he acidotic, that means his lactic acid is high, so that means this patient is in shock, is an anaerobic mechanism, so which is abnormal. That means there is no good oxygen supply go to the cells. So we start resuscitate the patient with IV fluid, with the oxygen, we give him medication, antibiotic, whatever, depend on the cause of the shock, and then we repeat it after half an hour or 15 minutes, we repeat the blood gas again. So if the lactic acid come down, that means the patient is responding. So number one, the most important cornerstone in follow-up patient with shock is lactic acid. Number two is urine output. So urine output mean, so patients now respond to IV fluid, so his body is full of fluid. Now the extra fluid is coming out in the urine, which is good news for the patient. So number one is the lactic acid. Number two is the urine output. But still, the most important one is lactic acid. Well done, Ahlam. So if the shock is became irreversible, the end stage, so shock is going to continue and destroy all the system of the body. So destroy the metabolic system by increasing the lactic acid. Lactic acid very toxic, and in the capillary and the blood vessel, you're going to get capillary, increase the capillary permeation, which means infiltration of fluid from the blood vessels around the vessel, get edema, and increase the third spacing of the fluid inside the body, inside the chest and inside the abdomen. Inside the chest, the most important thing, inside the lung itself, you get acute respiratory distress syndrome from the fluid accumulation inside the lung, which interfere the oxygenation of the body and decrease the oxygen, also increase the carbon dioxide. So all of these, if you look all the diagram by the end, each one is fired to each other. So each one like a gas with a fire, gas with a fire, gas with a fire, at the end by the death, unfortunately. So our aim in treating patient with shock just to avoid reaching the irreversible status. So we need to pick up the patient early in the shock. We need to treat him early. Once you have any sense of patient, this patient had shock or maybe is going to develop shock, keep the patient, don't send the patient home, admit the patient and start the IV fluid management and treat the patient immediately. So no one is going to blame you about the treating patient shock. You're saving life now. Even if there is no shock, you are not going to harm the patient. You're saving the life also. So what is the stage of shock? We say the initial stage, progressive shock stage, and irreversible stage. So same thing in the diagram, we put it for you in this timetable. So according to the pathogenesis, what happened and the effect of the pathogenesis on the body. Just read it and know about it. If you read the diagram enough, if you read this one is enough. So general clinical features. So if you have patient came to the ER and you suspect this patient has shock, so usually what we do in the ER, we do the vital signs, we take brief history, and we do quick examination. So this is what inside the slides, all these three. So you saw the patient, you take a vital signs, you take short history to know what's going on. If you don't know the patient, what's happened to him, maybe trauma, gunshot, whatever, or dental procedure he had done just 2 hours ago, and then you do your examination. So this patient, so clinical features, so you need to keep it in your mind. If you find patient hypotensive, which means his systolic blood pressure less than 100 and his tachycardic, his heart rate more than 100, this is question mark. This means patient had shock. So cold clam skin, cold, which means his skin is not warm. Usually your skin is warm, except in septic shock early. So you got very warm because feverish, because of fever, you got warm feverish skin. But in septic shock you got cold كلام سكين. كلام سكين مين كلامي معناها بالعربي زي ما يقول مرطب عليه زي الرذاذ، يعني لما تحط يدك على الجلد تحسي زي الغرقان، هو ناشف لك تحس جلده كأنه مبلول. cold and clammy skin. So rapid shallow respiration, drowsiness, confusion, and irritability. That's why we do the GCS score. So oliguria decrease the urine output. We know now why those patients have decreased urine output, because so the body itself, normal physiological response, need to compensate the fluid loss and increase the intravascular volume by reabsorb of the water from the urine. Usually absorb the water and sodium and excrete more salt. It's going to get more concentrated urine with less water. So elevated or reduced central venous pressure and multi-organ failure by the end. So from this slide, what is the most important point? If you saw it, you say this patient has shock. Guys, if you look at the general clinical feature in this slide, Abdulillah, perfect. He mentioned the two most important points. So I will let you know why it's not oliguria. So it is the blood pressure, systolic blood pressure, and tachycardia. Any patient, you have patient with low blood pressure and tachycardia. What does it mean? So low blood pressure mean patient shock, whatever kind of shock, and tachycardia. So the heart start initially to support the low blood pressure by increase the stroke volume. Try to push him more and give you more beats, more beats, more beats, more beats to compensate the blood loss or decrease the intravascular volume. So you got tachycardia. So sometimes you got the patient with tachycardia and normal blood pressure in trauma patient. So now the question, if you got the patient with tachycardia and normal blood pressure, which sign is most important now between low blood pressure and tachycardia? No, Abdullah, it's tachycardia. So that means by the end now. So if you have patient in department of trauma, in emergency department, so you put the patient on the monitor, you saw the blood pressure is 110, which is normal in lower limit, but still normal. But his heart rate is 115, which means is tachycardic. So what does it mean? That means this patient in shock. His heart rate, blood pressure is not normal because it's compensated by the heart rate. So the heart tries to push more blood to compensate and keep the blood pressure normal. So that means the most important things in shock patient, the tachycardia. So keep in your mind, your eyes in tachycardia. The patient tachycardic, that means there's something wrong with this patient. Even his blood pressure is normal. But as you said at the beginning, Abdulillah, so the most important 2 points, the blood pressure and heart rate. So heart rate number one, blood pressure number two. Why is not oliguria? I mentioned before for you, one of the important marker, the oliguria, decreased urine output. But maybe you go to patient in the ER, you have another cause of oliguria due to stone, due to benign prostatic hyperplasia or whatever. So another causes in shock patient for oliguria. But the most important clinical feature, so blood pressure and heart rate. Heart rate number one. So at this point, guys, is the question point for the exam. So So general principle for all the trauma patient need to manage in highly qualified doctor in highly monitoring area. So highly monitoring area, which means we need to put the patient on monitor in ICU or in ER on high care room department close to the nurse station, which means you need to keep your eyes on the patient the shock. So we need to put on electrocardiographic monitoring to monitor the heart rate and the ECG. We need to do the pulse oximetry to check the oxygenation of the body and reduction elevation of the serum lactate by giving IV fluids. So what is GCS? So GCS is Glasgow Coma Score. Glasgow Coma Score. So any patient come to the ER due to trauma or due to sepsis, the patient is not looking well. So we do the GCS, especially trauma patient. Glasgow Coma Score. It's a score we use for eye verbal and motor assessment. So eye assessment, motor assessment, and verbal assessment. So supposed to be 15 out 15. So we have 4, 5, 6 points. Supposed to be 15 out 15. Any guys like me and you. So glaucoma score. So full anyone normal person supposed to be 15 by 15. But any glaucoma score 8 is mean intubated. It means put tube for the patient. So give the patient sedation and put tube to protect the airway. So which means so any patient came to the trauma department or to your department, or even he came with glaucoma scores 15 in your table while you're doing the dentist procedure, and then the patient collapsed during the operation. Simple operation, dental extraction, and patient collapsed. So you need to assess glaucoma score. So patient lost consciousness. Now his liver consciousness is less than 8. He's not responding. So you need to protect his airway. Keep the suction in the mouth, put him oxygen, and put the tube into tracheal tube to protect the airway and prevent the aspiration due to anaphylaxis, due to trauma, due to whatever. Okay, and then we assess the other things. We start by airway. We say airway, the breathing, and after that the breathing. If the patient is conserving the A and B, and then we do go for circulation by checking the vital, heart rate, and blood pressure. This is the initial assessment for any patient with shock or trauma, whatever in the emergency, whatever happened to the patient in your table. So ABCD, we follow usually the ATLS guidelines. So once we finish ABC, and then we do D disability, we check the glaucoma score again, neurological assessment, and by the end we do exposure. So because most of the time you got patient in trauma, so you have multiple trauma, so you don't know where is the other side of injury. He had facial injury, multiple jaw fracture or dislocation, and then also he had humerus fracture, femur fracture, pelvic fracture, or gunshot in the face and gunshot in the back. So you need to do exposure, the full body exposure, by loosening all the clothes in the trauma department to remove and check the patient from head to toe. And at the same time, don't expose patient to hypothermia. So once you finish very quick, cover the patient and warm up the patient. You need to keep the patient warm. So what's the effect of the shock? So shock affect all the body system. So affect the cardiovascular system, affect the respiration. So cardiovascular system, okay, but decrease the preload and afterload, decrease the blood's going to the heart and the blood getting out of the heart, and the baroreceptor, the um, sympathetic receptor that control the heart rate of the heart itself, and release of catecholamine, tachycardia, and vasoconstriction. Respiration by making the metabolic acidosis due to what? Lactic acid, we said, and and respiratory rate and excretion of the carbon dioxide result in compensatory respiratory alkalosis. So on the renal system, the same thing, shock affecting by decrease the blood going to the kidney. The kidney start to stimulate the renin-angiotensin system, releasing the aldosterone and the other hormone from the suprarenal gland by increasing the vasoconstriction and increase the absorption of water and sodium to increase the intravascular volume. So microvascular, so the acidosis itself, lactic acid, so activate the immune coagulative system and lead to increase the release of the cytotoxin to damage the endothelium with the small vessels, lead to the edema. So on the cellular cells, is switch from aerobic to anaerobic metabolism. We say the same thing, so affecting the ATP system of the kidney of the cells itself. And then by the end, if you interfere, the sodium potassium pump is get impaired. So that means you are going to destroy the whole function of the cells. The lysosome inside release the toxins to auto-digest the cells and get the cells damaged and the death. And this is where the death start from. On carbohydrate, so compensated shock. What's happening? Compensated shock to the carbohydrate. So the body, so the hyperglycemia is due to increase the hepatic glycogenolysis. So the body feels there is something wrong, so increase the hypoglycemia by increasing the blood sugar to increase the requirement for the body. During the shock, it's happening, something happening like storm from the hormonal and mediators happen in the body. So the body feels that there is something wrong, going try to support the body with the energy. Got a lot of sugar inside your body. And after a while, so what is happening to your liver and your body? Consuming all the resources. You got hypoglycemia, decrease the blood sugar due to hepatic glycogen depletion, and increase the consumption of glycogen by tissue itself. So that's why most of the patients they came initial shock, you do the random blood sugar, you found they have high sugar, you thought those patients they have diabetes while they are completely normal person before they didn't have diabetes, and after that they got really badly drop in the blood sugar and lead to coma sometime and affect interfere with the Glasgow coma score, give you confusion and drowsiness. So the aerobic glycolysis occur also in assist by the high blood level of the lactate and pyruvate. So on the protein level, so metabolism increase the intracellular protein catabolism because of the depletion after depletion, the hypoglycemia. So conversion of amino acid to urea and increase the urea secretion by the urine. And the fat metabolism increase the endogenous fat metabolism and raise the fatty acid level in the blood. So water and electrolyte disturbances got also destroyed because the failure of sodium and pump of sodium potassium pump in the kidney level, the nephron level. So initially your body tried to compensate by absorb more water and more sodium and then affect the balance of the body. You got very highly concentrated urine. So the body can't compensate for a while, and after that, if you don't interfere and give the patient IV fluid, so the normal physiology of the body is going to be destroyed. And at this moment you need to know which IV fluid you need to give the patient. So the most suitable fluid for resuscitate the patient, the crystalloid fluid, either normal saline or ringer lactate at the beginning. It can support the patient up to 2 liter, which means it's 4 liters of 500 ml. So metabolic acidosis, we know now about metabolic acidosis is usually due to the lactic acids. So case for metabolism, for anaerobic metabolism. Yes, four. So usually each bottle contain 500 500 كل واحدة فيها فتعطي 4 almost. So this is the maximum you can give Abdulillah. You give 4, which means 2 liter as resuscitation bolus. You can give it as a once. Okay, so Abdulillah, so once you have a patient with shock, low blood pressure, and high lactic acid, so what is your job now? So you need to give the patient IV fluids. So which kind of IV fluid is safe to give the patient? It's not interfering with the normal physiology. ما يأثر على normal physiology. So انت عارف البلد جوا ايش فيه؟ في blood plasma electrolyte, a lot of things. If you get like normal saline. So normal saline is not the perfect 100% good water, good IV fluid. You need to give it to the body of the human body. So, but if you have patient in shock, that means his blood pressure is low. He's not compensated. You need to save this life. You need to keep the patient alive because after 2 hours or half an hour, if the patient came late to the hospital, you are going to lose the patient. Is going to die. So you can give him resuscitation fluid up to 2 liters, which means 4 bottle. So what kind of fluid we give the patients? Either normal saline or ringer lactate, which we call is crystalloid fluid. I a crystalloid fluid, the most safest fluid we give it to the patient. Okay, hypoxemia also encephalopathy. So why we got hypoxemia due to encephalopathy? We said something about the brain is very important. So brain is the only organ in the body got control auto-regulation of the blood flow. Once you got shock or decrease the oxygen or increase the carbon dioxide. So if your body is not tolerated to compensate the shock, so that's why the patient they got decrease the blood supply to the brain and got confusion, drowsiness, and change in glaucoma score. So in the heart, on the heart level, so shock itself. So due to decrease the oxygen and increase the lactic acid, massive lactic acidosis. So you got hemorrhage and necrosis inside the muscles of the heart itself. Usually, where is it located? In subepicardial and subendocardial region. So inside deep from the heart. Why we got inside deep from the heart? Because the blood supply of the heart is coming from outside from coronary artery and going deep inside all the way to the muscle. So The most deepest muscle don't get the blood, it's get necrosis and dead from inside. So shock of the lung. So most of the patient, if they don't get treated after gut confusion and physiological abnormality, decrease in the blood pressure, they end in the ICU. If you look to the X-ray, if the patient was shocked in the ICU after day 1 or day 2, you saw his lung is completely white. So usually we saw the lung in the X-ray is black because if the airs appear in the X-ray is black. Why we saw it white? Because there's acute distress respiratory syndrome, acute respiratory distress syndrome, which it means so infiltration of interstitial and alveolar system of the lung by edema and fluid and lymphocyte. So this is make a fire on the patient of the shock because as much as oxygen is given by the ventilator while you ventilate the patient, there's no more oxygen going to inside the body to the bloodstream. So you need to stop everything before these major things happening. So shock on the kidney and the adrenal gland usually the same thing. So we saw ischemia drive the kidney to make and release some hormonal from the kidney and increase the anuria and increase the absorption of the fluid of the water and sodium from the urine to increase the intravascular volume. On the adrenal show stress response in the shock. So release aldosterone in response to hypoxic kidney and release the glucocorticoid from the adrenal cortex and catecholamine like adrenaline from the adrenal medulla also. So that's why some kind of patient, if you have any procedure for surgery, so any patient with the adrenal problem, so most of them they came undiagnosed with Cushingoid syndrome. Cushingoid syndrome patient he came with the bad fat distribution, the moon face, round face, يجي مريض وجهه كده مكور كله فاتي وظهره محودب من كثر الفات وعنده سترايا في السكن، عنده هشاشه في العظام وسكر، هذول كلهم عندهم ادرينال بروبلم. سو يسمون كوشينويد سيندروم. اذا شفت اي مريض من هذا لازم تعمل له هرمونال ورك اب قبل اي بروسيجر، لانه اني بروسيجر كان جيف يو ادرينال ستورم، يدخل المريض في شك فجاه عشان عنده الهرمونال امبالانس حاصل. فاحنا في الجنرال سيرجي لما يجينا المريض هذا نكتشف بس انه من الشكل بس من الاكزامينيشن هذا كوشينويد، يعني عنده ريحه بس ابنورماليتي في الادرينال جلاند هرمون. سو على طول نرسل له بلاد ورك اب ونرسل اندوكراينولوجيست تو اسيس ذا patient is it fit for surgery or not fit for surgery. Unfortunately, most of those kind of patients they came to your clinic you don't know. For simple procedure and the dentist, you give him local anesthesia, you start your operation, and then by the end he got collapse or anaphylactic shock. So you didn't have time to save his life. If you have any patient with the adrenal problem, you have any feature of Cushingoid syndrome, so just do the workup, send them to the medical department in the hospital, and tell them to clarify and do the hormonal workup. So in the GIT system, so we consider the mouth and dental area from the GIT system also. Hypoperfusion of the alimentary tract lead to mucosal hemorrhage and submucosal hemorrhage and lead to ulcers and de-sloughing the mucosa. And most of the time, the patient in the ICU after they got choked by 1 or 2 days, so they got bleeding per mouth or bleeding per anus from number 2. So very dark, bad, offensive blood is coming out because of this process. They got hemorrhage in the most inner deep layer of the JIT system and lead to ulcers and bleed. So on the liver, so the hypoxemia itself, the decreased oxygen delivered to the liver, so give you a vasodilator modulator, the release lead to vasodilatation, and other include the focal necrosis in the liver, fatty change in the liver, and decrease the energy resources in the liver. So it already got consumed by the shock. So this diagram is showing whatever we talk about it. So each organ is affected by shock. So the whole body is affected by shock. Skin, small bowel, large bowel, heart, lung, brain, whatever. So that's why. So by the end, we said the patient have multi-organ failure. So if the patient with shock has got multi-organ failure, unfortunately, this is a irreversible stage of the shock. So we need to treat the patient before reach any single organ failure. So ischemic reperfusion syndrome is not that important. Just read about it. It's not important. It's related to the shock, but You need to know about it, but it's there is no question. It's not that clinically important for you. So now again, so the most important kind of the shock you are going to face in the hospital, general hospital, if you hear about it, the hypovolemic shock. That's why we need to talk about hypovolemic shock a little bit in detail. So occur from inadequate circulating blood due to trauma. So due to whatever cause lead to the bleed. So major effect is due to decrease the cardiac output by decrease the blood coming to the heart. So that means there is no blood is going out from the heart. So the severity of clinical feature depend on the degree of the blood volume loss. So how can we estimate the blood volume loss? So if you have blood loss less than 50%, so this diagram is not that important. Just read about this. So I want you to concentrate on this on this slide. So this slide so classify the hypovolemic shock according to the hemorrhage itself. So how much the acute blood you lost. So how many liters of blood you have in your body? Guys, how many liters of blood we have in our body? So we have almost around 5 liters of blood. So if you lost 15% of your blood, so if you lost 15% of your blood is a class 1. If you lost from 15 to 30, so which means 1000 to 1500 is class 2. So and then class 3 and class 4. There's 4 classes of the hypovolemic due to hemorrhage shock. So the most important things you need to know about. So what is the parameter that you're going to told you? So if you look here to this table now, so the blood loss in the by mil, so class 1, 2, 3, and 4, and then the pulse rate, the blood pressure, the respiratory rate, urine output, and fluid replacement. So which one is the most important parameter? Told you about the amount you can follow up with the patient to know how much of or to classify the patient at class 1 or 2. So which one? No, Ahlam, it's not the blood pressure. So all of them important, but it's something you need to know it by numbers. Heart rate, Muhammad al is good. So heart rate. So heart rate, the most important things to know how much or which class of shock patient had due to hypovolemia. So this table that mean, so what you need to know this table, I need to know if the patient have heart rate less than 100, more than 100. What does it mean? Class 1, class 2, and class 3 is more than 120, and class 4 is more than 140. That's all from this timetable. You need to know the heart rate and which heart rate mean which class of the shock in hypovolemic shock. So sign of symptom of hypovolemic shock, as we mentioned generally, so an anxiety, patient become restless and have an anxiety, altered mental status. So يجيك مخبط ما هو عارف يحارب يضارب ما في شيء نزف شويه خلاص يشوف ما يشوف and by the end before it collapse he told you that he have a tunnel vision I can't see you يعني قبل لا خلاص يحصل اذا ما في اي انترفنشن نو اي فلويد از جيفن نو بلاد از جيفن نو ريسسيتيشن يقول لك انا ما اشوف انا اشوف زي النفق اسود خلاص عيني ما اشوفك يا دكتور خلاص بعدين خلاص يحصل له كولابس جلاس كوما سكور يصير 8 ما عاد يشوفه عاد في اي ريسبونس so he start by anxiety restless altered mental status hypotension due to blood loss rapid weak 3D pulse is not compensated and cold clammy skin, rapid shallow respiration, hypothermia, thirsty dry mouth due to blood loss, and distracted look in the eye. If you talk to him initially before he became comatose, so he doesn't give you this eye contact. شوف الآن لما أتكلم عليك يا محمد ودعاني اتكلم معاك تتكلم معايا تشوف عيني في عينك تمام ما في اي كونتاكت تحس نفسك تتكلم معايا طالع فوق يمين يسار فوق تحت ما هو معي في something wrong حتى لو انه يجاوبك صح وعارف وين هو عارف وين عمره وين كل شيء لما تسال عن جلاسكوما سكور تلقى فيه ديستراكت تشتت هذه first sign of confusion and restless first sign of drop in the glaucoma score. So compensatory mechanism what's happened so now body again is going to do the normal physiological function, adrenergic discharge. So adrenal glands going to secrete hormone to support the body by increase the vasoconstriction and absorption of the water. Same thing we talk about it in hypovolemic shock, whatever kind of shock. This is compensatory mechanism happen with any kind of shock. Hyperventilation, due to what hyperventilation? The body need to wash out the extra carbon dioxide inside the blood, and vasoactive hormone we secreted from pituitary, from adrenal, from the kidney also, angiotensin, vasopressin, and epinephrine. So collapse and reabsorption of the fluid from interstitial fluid to increase the intravascular fluid, and reabsorption fluid from intracellular to extracellular space, and renal conserving of body fluid and electrolyte by reabsorption the water and sodium. So clinical monitor, as we said, as any patient or situation in the hospital, you need to monitor the patient high care monitoring system by monitoring the blood pressure, respiration, cardiac monitor, ECGs, central venous pressure, and both the catheter to know how much urine output. And according to how much urine output, you need to give patient fluid. If the patient have very low amount of fluid, oliguria, decrease the urine, so you need to give him resuscitation as 2 liters of IV fluid. If there's no response, you need to give epinephrine, something we call vasopressin, to increase the constriction of the blood vessel, increase the high blood pressure. If the patient increase the urine output, and then depending on how much urine output is coming out, you're going to replace the IV fluid. Let's say the patient, you go to the back of the urine 1.5 liter of the urine in the 2 hours. So that's mean you need to replace this amount of IV fluid in the same time. So you give him 1.5 liter of IV fluid. So that's mean the patient now have zero balance in the body. You need the same amount coming out, same amount of fluids going in, till the patient discharge or getting fully orally intake by his mouth. او المريض يقدر يشرب بنفسه وياكل بنفسه، خلاص اوقف الاي فلويد وخلاص اخليه هو يعتمد على نفسه. اذا ما في، so the same amount of fluids coming out, I need to replace it by IV fluids. So swan gas catheter, we use it for the cardiac patient with the shock in the cardiac ICU, in the major ICU due to cardiac origin shock. So this slide also same thing what we mentioned about the previous slide, what we are going to do. So we don't forget to mention something about the blood. So in hypovolemic shock, what's the major concern? What's the major problem? The patient lose blood due to trauma. So initially, so if you ask for blood from the blood bank while you have patient in shock, so blood bank it take around 15 to half an hour to get the blood. Emergency blood you can get it very quick in 10 minutes. But if you get more blood, they will ask you to do cross matching for the blood, which you need 30 minutes. So that's why we said we resuscitate the patient with the 2 liter of IV fluid, and then we got the emergency blood. So the patient lose blood, that means patient need blood number one. But because blood it takes time and patient critical care might be is going to die, so we need to give him something to support his physiology. We give him IV fluid. But the initial, so the idea you need to give the patient blood. If you have patient the blood ready for the patient, give the patient blood. So, and this is diagnosis in management of patient trauma. So it's not related to our work as a dentist, because for any case of trauma, so to manage the case of trauma, you need to know, is to manage the case of the shock, you need to know the cause of the shock. If the cause is trauma, so you need to treat the cause of trauma due to fracture, due to gunshot, due to stab, due to accident by the car. So you need to fix whatever is going to be broken to stop the bleeding, to stop the wound bleeding. It's due to sepsis, you need to give patient antibiotic and drain the site of the abscess to stop the sepsis. So the treatment is depend on the cause of the shock itself. So the management, the corner and idea, cornerstone, the idea behind the management. So you need to increase the tissue perfusion with the blood. You need to deliver more oxygen by the blood to the tissue, to the cell itself, either by increase the cardiac output and increase the tissue perfusion by increase the blood pressure. So the plan of action, your plan of action should be fix the problem. So know what's going on, So adequate fluid replacement, we say we give crystalloid up to 2 liter, improve the myocardial contractility usually by the IV fluid by increase the intravascular volume, and correct the acid base imbalance. The lactic acidosis is very bad for the human body. So once you give the IV fluid, you're going to dilute it, make it diluted. So our body is going to react with it and tolerate it. But never stop the IV fluid, or don't give the patient IV fluid if you have lactic acidosis. You need to start the so IV fluid as much as soon as you can once the patient had lactic acidosis. So this is what we mentioned it. So same thing we talk about it: IV fluid, monitor the patient, give him sedation, antibiotics, and something to support the heart. So distributive shock. What we mean by distributive shock? So we mean we don't have hypovolemic shock. We don't have loss in the blood volume. Blood volume is the same. So this is the main difference between hypovolemic shock and distributive shock. So distributive shock, we have the same blood inside the body, but the blood vessels itself became very relaxed. It's very wide and very dilated. So the blood cannot be pushed to the terminal cells to get the oxygen. So what is the causes? What is the example and causes for the distributive shock? So septic shock, anaphylactic shock, and neurogenic shock. This is the most three important things can give you distributive shock. So traumatic shock. So traumatic shock can be mixed between a lot of shock. So usually primary due to hypovolemia, due to bleeding and loss of blood, and then it can be conjoined with the other problem. If you have spinal cord injury and trauma, you got neurogenic shock. If you have sepsis, you got septic shock. And then so traumatic shock usually is multifactorial shock, and is a new terminology. We use it in trauma surgery only. So if the patient have crush injury, multiple trauma, we say traumatic shock and trauma shock. That's all. So otherwise, it's not one of the main cornerstones of the shock or subtype of the shock. So pathophysiology is the same thing like any pathophysiology of the shock. All the pathophysiology, the aim, so decrease the oxygen delivery to the end of the cells, to the end of the cell. And management is the same also. So you need to assess your patient by ABCD according to the ATLS, and see the patient Glasgow Coma score, is it fit or not fit. Is not fit, you need to put the ET tube in the tracheal tube, and then assist the patient by doing the surgical management, either fluid management, support the patient, keep the patient in ICU or in high care unit. And the patient, you can sometimes give patient anticoagulant with intravenous dose, just heparin, because most of the kind of the patient is going to be bedridden, so they are in high risk for DVT, to develop DVT. So cardiogenic shock, we talk about it, and it's not that important, because usually we saw it in two categories. So cardiogenic shock either present in old patient due to cardiac problem, old patient, or in young patient with trauma to the heart, usually due to stab heart, and any massive myocardial infarction affecting the contractility of the heart. So usually, so it can be presented as one of the two mechanism, either dysfunction of the right ventricle or left ventricle. Is very rarely would go the both system together. So right ventricle just affecting the right side of the heart, shock due to the right side of the heart. If you got left ventricle is not treated, and the patient is, so the human body is going to compensate the right side, but after a while, if you don't treat it, it's get both side ventricle um, damage of the heart. So usually, if you have it as a surgeon or as a doctor, so we have specialized doctor in the hospital, you need to deal with a cardiogenic shock. So we send the patient to cardiology, because they have very special an instrument to measure the contractility of the heart by echo, and give the patient special medication to increase the contractility of the heart. And sometimes patient need to be admitted in the ICU, and give them swine gas catheter, something catheter we put it by endovascular device to increase support and contractility of the heart inside the ICU. But in this situation, patient need to be admitted in the ICU under sedation, intubated like he's going for operation inside the ICU. So there is another subtype of cardiogenic compressive shock. So due to tension pneumothorax, if you got any stab or gunshot in the chest, air leak inside the chest cavity, increase the pressure around the heart. So once you get increase the pressure around the heart, is affecting the heart itself, or by accumulation of the blood around the heart inside the pericardium, we got pericardial tamponade and diaphragmatic rupture and herniation of the bowel inside the chest cavity lead to decrease the space inside the chest and affecting compressing against the heart. So all of these slides now, so it's not that important. Just you need to know about it. You didn't need to read it too much. You didn't need to get any information for the exam. So just you need to know the subtype as as the main things. So clinical features same thing as any shock except for the right side and left side. So the right side the patient got abdominal pain due to increase the liver size increase and got distended neck and swelling in the legs. This is the most important things. So this picture also simplifies the cardiogenic shock and how it affects the body. So management, as we said, most of the patients sometimes they need IV special medication for the heart to increase the contractility for the heart. But usually those kind of patients we do not to know lots of things about them because even we are in surgery, we send those patients to cardiac department to cardiologist. Cut, so decrease the neurological supply. So spinal cord supply all the blood vessels in your body. So it gives you the normal blood pressure, contraction and dilatation of the blood vessels driven by the neurogenic by catecholamine. So if you got energy in spinal cord, you loss of this control. So which means the patient got vasodilatation. So his blood vessels dilated. He got distributive shock. So he came to the department of blood pressure. So 80 over 40, 80 over 50 as very low blood pressure. You give a patient IV fluid. The same thing is not improving. Why? Because there is no neurological effect on the blood vessel. So those kind of patients so need ICU admission, intubation, and vasopressin. So epinephrine and norepinephrine. This is the hormonal medication secreted by the terminal neuron on the blood vessel to give contraction and dilatation of the blood vessel. So you need to give the patient epinephrine and norepinephrine to increase the blood pressure. And usually the talk times from 1 to 2 weeks to respond to the medication. So clinical feature of those patients is they got warm skin, pink, and well perfused. So you look to the other kind of shock. So patient got cold, clammy, and very blue or pale because there is no blood is going to the tissue. But those ones got pink because the blood is good going to the end of the tissue. And heart rate is rapid and the blood pressure is low. So unfortunately, this one is mistake. So in neurogenic shock, the heart rate is low. It's not rapid. So it's rapid, but it's low heart rate. Why low heart rate? Because they lost the communication between the heart rate and the neurologic system. So there is no neurological system, neurological supply to the heart. So the heart it doesn't know if the body in the shock or no, because you found the patient have very low blood pressure, supposed to have tachycardia, but those kind of patient you find low heart rate. You low heart rate is below the 100. So pathophysiology, we talk about it. So management will say two things they need after stabilize your position. You need to put patient Trendelenburg position, which means you need to put his head down and leg up on the bed and give him IV fluid and vasoconstrictor medication, as we say, epinephrine and norepinephrine. This is the most important treatment for neurogenic shock. So vasovagal attack or vasovagal shock is same like neurogenic shock. We treat it same and usually is completely compensated by the body with the matter of the time. Within 5 to 15 minutes, the patient became normal. But during the acute situation, you need to lift the patient leg up to increase the blood supply to the brain. That's all. Otherwise, you need to give the IV fluid and monitor the patient for a while, and then most of them they will recover completely 100% normal back. So psychogenic shock is same thing, like it's a subtype of neurogenic and vasovagal attack. So usually we didn't have special treatment like antibiotics something, but sometimes we have very bad situation. Can lose the patient due to unconscious, due to decrease. You have massive, very bad drop in the blood pressure. So septic shock. So the one of the most important in your work is septic shock. So what is the most common sepsis in your work, guys? Where can you get sepsis? Where can you get sepsis, guys? It's not for the instrument. No. Where which kind of procedure? Usually most of the procedure, so they have risk. So an instrument and needle is source of sepsis, Abdullah. But what is the most common form of sepsis in your work? What is the most common diagnosis of sepsis? No diagnosis. I'm not asking about the sources. Shabib, what is the most common diagnosis in the mouth when you do any dental procedure? So did you hear about peridental abscess, bulbitis? Yes, peridental. This is the most common. Yes, because peridental abscess is the most common source of sepsis. So in septic shock, so usually you have source of sepsis. You have source of sepsis, you have infection. So sometimes abscess, sometimes without abscess. So sometimes you have abscess because the source of the abscess is infection. Sometimes abscess without infection. Most of the time due to toxin. So some bacteria give you endotoxin and exotoxin. So once you got this toxin in your body, you get anaphylactic shock from the toxin, you get shock. So shock can give you very severe septicemia, which means there is high level of the toxin in your blood. So you got low blood pressure, high body temperature, you got fever, you got high heart rate, and the patient became very bad mental status, decrease the conscious level. So septic shock we need to treat it a little bit differently. So all the shock at the beginning we have the same thing. We said we need to put IV fluid, assist the patient, check for glaucoma score, and give the patient IV fluid at least 2 liter of fluids to resuscitate his blood pressure. But by the end, so in septic shock, you need to do two main things. So if you have any source of abscess, what you need to do with this abscess, we have peridental abscess is source of abscess. You need to drain it. You need to open the abscess. You need to open the abscess, evacuate all the pus, and wash the cavity. Yes, evacuate the abscess because the source of the abscess, as much as you treat the patient while the abscess is there, is not going to treat the patient because the source for the toxin and bacteria is going to your bloodstream. Second thing, give IV fluid, take sample before you give antibiotic because this is infection. So you need to give the patient IV fluid. You need to give the patient IV fluid and you need to start antibiotic. But never, please, never start antibiotics before you get the blood culture. So put your needle, get a blood sample for all the worker, for CBCs, for renal function, for whatever you want, and take one bottle for blood culture. And then blood culture grow gram-negative E. coli bacteria, sensitive to augmentin, and your patient's already on augmentin. So continue the augmentin. And if you told him you need to change your antibiotics, so that's why at the beginning we give the patient what we give patient broad spectrum antibiotics. So we don't need to wait antibiotic study from blood culture. You give him something broad spectrum at the beginning after you get the blood culture and wait for the blood culture. Once the blood culture finalized, call the blood microbiology department in the lab every day, every morning, and ask about the culture if grow anything, what kind of bacteria, and sensitive to which antibiotic. They will tell you which antibiotic is sensitive to. If sensitive to the antibiotic you already use, continue. If it's not sensitive, change it to the sensitive one according to the culture. This is the only way to treat the septic shock. So, and keep in your mind, so treatment is two-way. Treat infectious and treat by supporting the normal physiology of the body by IV fluids. So this is what we mentioned, the most important things. Read about it, guys. Same thing we talk about it. Fluid, antibiotic, debride, and evacuate the source of infection. Whatever the patient is more sick, put the patient on the ventilator and do whatever you want. So sometimes we mentioned the middle steroid. So steroid, sometimes the patient they don't respond to antibiotic, they don't respond to vasopressin to increase the blood pressure. So we give steroid to increase the functionality of the vasoconstrictor, increase the blood pressure. That's only a cross-bridging medication. Otherwise, we don't like to use it as much um, for long time because of side effect of the steroid. So anaphylactic shock. So is it important kind of shock or no? We almost there. We are going to finish, guy. We almost. I know it's long seminar, long lecture. So anaphylactic shock is it important or no? Yes, allergic due to penicillin. Yes, non-steroidal is rarely. Penicillin is very common. What else in your clinic as a dentist while you're doing procedure can give you anaphylactic shock? Something you injected also. Yes, local anesthesia, أحلام, perfect. So the most important things, antibiotics, sulfa component antibiotics, and local anesthesia. We have some patients, they are allergic to local anesthesia. You inject the local anesthesia, you get anaphylactic shock. So the bad thing of anaphylactic, so the first thing, the good thing with anaphylactic shock, the first time you receive the source of the anaphylactic shock, let's say medication or toxin or whatever. So the first attack is going to be very mild. So, and then your body, what is going to happen to your body? So the mast cells and the white blood cells, I'll show you the picture now. So the white blood cells, so you got the antigen, whatever the antigen, the yellow ones. So you got the antibiotics, the local anesthesia, whatever making the allergy. So your body, the B cells give IgE. IgE is going to attach to the mast cells, the other white cells. So the white cell mast cells secrete all the stuff of interleukin and mediator lead to allergy. So the second attacks mean, so you've got the antigen again. Now all your body mast cells is loaded with IgE, it's ready to receive this antigen. So the second attack is going to be very bad attack. It's not compared to the first one. If you have patient in your dental clinic, you give him local anesthesia, and then you notice that you have allergy to local anesthesia, please tell him that you are allergic to local anesthesia, this kind of local anesthesia. I need to do allergy test in the allergy clinic, usually with the dermatology or autoimmune the medical department. So to know which safe local anesthesia to use with this patient, because the second attack if you give him is going to die if you don't treat him immediately, very aggressive. It can be reached to the ICU. He need intubation second time, definitely. So what's happened with the anaphylactic shock? We said once you inject, you have another general feature. What kind of general feature can you get on the patient? Increase the heart rate, shortness of breath, edema in the mouth, in the laryngia, in the epiglottis. You got shortness of breath. That's why those kind of patients they need intubation directly. If you have any lip swelling, difficulty in breathing or talking, even just calm your patient down. Just try to reassure the patient and tell them we're going to intubate you. Yes, lip getting bigger. So told the patient we're going to intubate you. Give him medication first. If it not improve within minutes, put the intubation, because as much as you wait for the patient to improve, as much the swelling and edema is getting bigger around the lip and the airway, and becomes very difficult intubation. Especially in your clinic, you didn't have the crush trolley, you didn't have expert doctor around you like ICU, because sometimes we are surgeon, we struggle to put the tube in for intubation. We need the ICU doctor or doctor from anesthesia department from the OR to come and put the tube for us. So from the beginning, if you find this anaphylactic shock is going to progress, put the tube by yourself early. Give the patient sedation and put the tube, save his life. So no one's going to blame you. You are going to save lives now. So how can you manage? We say position of the patient, stop the trigger, stop the injection, the or giving the antibiotics or whatever causing the anaphylactic shock. Do the ABC according to the trauma ATLS course, and definitive cause. Stop the antigen that make the allergy number one, and then after that administer the epinephrine, the most important medication to treat. So oxygen initially, so oxygen we start before everything. Is number B is supposed to be A. We give oxygen from the beginning to increase the oxygen. But A, so the main معلش في ازعاج عندي ناحية شوية. So the most important things to treat the anaphylactic shock, it is the epinephrine. We give it subcutaneous, we give epinephrine as much as you can till the stop the anaphylactic shock. So monitor the vital signs, and additional drug therapy you can give corticosteroid and antihistamine to decrease the edema in the airway. The most important thing to protect the airway. If the epinephrine is not working, give antihistamine and corticosteroid also. But the most important one, number one, epinephrine. So prognosis of shock. So shock we say is very bad situation for the patient. If you don't treat it, the mortality rate reach up to 80%. If you look like to 75%. If initially it's going to be 20%. If you treat it from the beginning, you're going to save the life of the patient up to 90%. That means the patient going to die, you make him 90% going to survive. Is something great if you interfere in the early beginning stage of the shock during the reversible state. If you reach the irreversible status, now you are gambling with the life of the patient. So most of the time, patient in the ICU, you don't know is going to survive, is going to live or to die. You don't know. So day by day, you need to monitor your patient, you give medication, you call a lot of colleagues from different departments, from the pulmonology, from cardiology department, from ICU, you don't know what's going on. But your cornerstone to start interfere, treating the shock from the beginning during the irreversible initial stage of the shock. It's all we treat, we talk about it, all kind of shock and how we treat it, same things. So dental consideration, the shock. So what you need to do before or to avoid, so what you need to do, so what you need to understand to avoid any shock situation before it's happening in your clinic. So through the diagnosis and treatment plan of your patient, you need to ask about the allergy and systemic review of the patient about anything, any experience before. Does he had allergy to any medication, or does he had any admission to ICU, to hospital due to allergy or shock, whatever kind of cause, you need to ask before any procedure start. So local anesthesia used during the dental treatment, we say it's one of the medication can give you anaphylactic shock. So pain and anxiety. We saw some patient. We hear about some situation of patient guys. You use the metallic injection needle. Some of them they have psychogenic or vasovagal attack from this procedure. So you need to reassure your patient before. You need to calm down his anxiety and told them it's very simple operation. As the needle just only is different from the other needle. A needle just only different from the other needle. So you need to explain all the procedure to avoid any situation of the shock or any situation of an anxiety itself. So management of dental office is the same of the management of each shock, but I put it for you in diagram, guys, just to read about it. But if you look to the steps and situation, all the same. We have two diagram I put for you. Just read about it. All simple, all same. This first one, this is second one. Yeah, conclusion. Social shock can present a consequence of multiple causes. We mentioned all the causes give you the subtype of shock. And regarding the shock, the sources of fundamental primary treatment of shock remain recognition and promote the fluid replacement therapy as much as you can, as you figure out or you found you found the early stage or initial stage of shock. So, and the research of underlying cause of the shock is the only initiated after stabilization of the shock. If you have patient with the shock, once you stabilize the patient, you need to stabilize the safe life of the patient, and then look for the source of the shock, the next step, and do the treatment according to that, according to the subtype of the shock. So references. So we have a lot of references. I don't think you need to read from any book. So this is our attitude with our student in the medical school. So we give them the topic. We try to avoid give them the PowerPoint, but we give them the resources to read from the resources that we got. Um, we got the resources, the information from, but from for you as a dental school, I know that is a big topic. It's long. It's a lot of data, but it's simple. We try to get everything in the PowerPoint. I'm going to share the PowerPoint with you. So now the final things. So what I'm going to talk about. So I'm going to talk about what kind of the question. How can you get the question in your exam? I know most of you are very suspicious. You're concerning about the marks more than about the knowledge. So what do you think kind of question you are going to get? آمال نصابة تبغى أسئلة هذه دايركت طبعا. So what kind of question you are going to get and how can you get the question? I'm going to give you the key for the questions. Um, so so you are going to get some scenarios. Abdulillah, you are going to get some scenarios like I'm going to say you have patient in your clinic while you're starting the procedure. You explain to your patient the procedure. You give the local anesthesia while you're doing your procedure, the patient got shortness of breath. And then I'll give you small things about the vital signs. And it's going to be like straightforward question. What kind of shock your patient develop? You know those kind of questions, straightforward questions. Is it simple? Okay, second thing, we are going to make a little bit different. So I'm going to give you a long scenario about shock patient, and then I'm going to ask you about what kind of shock and how can you differentiate between is it neurogenic shock, is it hypovolemic shock, and also simple questions, something like that. So what I mean, so you need to know, you need to read what kind of shock, how can I differentiate, what the pathophysiology of each shock. And hypovolemic shock, keep in your mind the heart rate is the most important things. You need to know the class one, two, three, and four of shock. What else? And the most important, the sepsis shock. So if I ask you questions about shock, I need you to know the kind of shock and how to treat it. Especially, so definitely we have some kind of shock is treated from the other. Let's say in hypovolemic shock, what is the most important cornerstone in the treatment, and septic shock, what is the most common. So both of them initially IV fluid, you need to support patient IV fluid, but the definitive in hypovolemic shock, you need to fix the bleeding point and to give blood. In septic shock, you need to give antibiotic to treat the source of sepsis after evacuating or control the source of sepsis. So this is our situation. This is our questions going to be like that. Clinical diagnosis, clinical scenarios. Any question from your side, guys? الفاروق اسمك حلو. طيب اوكي. خلاص الظاهر إن طولنا عليكم زيادة، الشباب كلها بتهرب. لو if you have any question about the topic, just send me on my WhatsApp. Most welcome anytime, 24/7. Send me WhatsApp. I'm going to reply to your questions. Okay. Thank you very much, guys.